Now, what I like to do on these cases in particular is a blunt dissection towards the mental foramen. Once we identify the mental foramen, which you can see clearly right here, we then want to come 5 millimeters anterior. So the first implant I will always place will be the most posterior implant. And the reason for that is when we're working interforaminally, that's going to maximize our AP spread. Okay? So in this case, we're going to stay 5 millimeters anterior to the mental foramen. And why is that? A lot of our CT scanning studies have shown that there's an anterior anastomosis of the inferior alveolar, and it at most traverses in a small percent of cases at least 5 millimeters anterior. So the first implant with the insertion of the syncone. Once you place the first implant and the syncone, you are then going to place a parallel pin. I'll show you those on the next case. That is going to give you the capacity to truly keep your implants within 5 degrees of parallel. So once you've placed both implants on the distal, critical component, 5 millimeters anterior to the mental foramen, you can then place your other 2 implants. Now, I'm not showing it, but what I did on this case was I used the denture as a surgical guide. So you'll begin your twist drill pilot sequence. You'll first mark through your denture with the number 6, and then you can drill your osteotomy with a 1.8 all the way up your sequence. But you can use your denture as your primary surgical guide in these cases. It's a very simple, very effective way to manage them. So when you reline, after the implants are placed, be sure you entirely grind the whole denture out. So it's not a segmental reline. You must reline the whole denture with hard, cold cure acrylic. No light cured material, a full reline. My suggestion is once you have primary closure, you want to use a more durable suture material. I don't recommend gut, a PGA, silk, something that's, or Gore-Tex, something that's going to be more long-term resorbable. And then coat the tissue with aloe vera gel or something that's going to create some viscosity so the acrylic won't bind to it. So we see here we have 4 6-degree syncones. Now, we're going to talk about the degree of retention as we go on here. But the next thing you're going to do is place the spacers onto the implants. So these big round plastic spacers go on, and then you simply take the gold retainers with gentle finger pressure and place them onto the abutment. At this point then you're going to try in your denture after you've relieved it to make sure you have adequate clearance. Put your cold cure acrylic into the denture, seat it into the mouth, have the patient bite into maximum intercuspal position, and hold. Hold that position until your acrylic has set to completion. Once that is set, take the denture out, remove all the flash, polish it, insert the denture for 2 weeks. You do not want the patient to remove the denture for 2 weeks. Now, what did I tell you about primary stability? Critical, critical. The unique part of the Ankylos implant system is after you place your implant, there's a cover screw. The cover screw turns counterclockwise with an instrument in the surgical kit. That turns out at 24 Newton centimeters. Okay? We look for parameters for optimal primary stability. If that implant twists at 24 Newton centimeters, you probably don't want to immediately load. So utilizing the removal of the cover screw as a clinical parameter to determine if you can immediate load is a safe way to go, particularly in the type 1-2 bone on the lower anterior mandible. This is showing 1 week healing of the 4 6-degree abutments. Now, Choosing your abutments is very important. If you put 4-degree abutments on, syncones, you may find that it is too retentive. So you are better off to put 2 4s and 2 6s or all 6s to begin with, because you can always go to the 4s and develop more retention. So be aware that placing all 4s is extremely retentive, and in particular our elderly population may not be able to remove that. Here's a 1-year post-op of the 4 6-degree syncone abutments in place, and the final denture reline as it is in the patient's mouth today. Now understand, when you place the syncone abutments as well, there is no driver that is needed. Because of that unique interface on the Morse taper, you simply need 15 Newton centimeters of force to seat the abutment into the implant. We can generate 15 Newton centimeters with finger pressure. So finger pressure, solid finger pressure is all that is needed to secure the abutment into the Ankylos implant. So let's demonstrate another case on the mandibular arch. We see on the left side several remaining teeth. This case, we are going to develop the positioning of the implants more posterior. The occlusion of this patient was not a full maxillary denture. This patient was going to have a fixed implant supported reconstruction on the upper, generating a lot more force. So our goal was to be able to provide more posterior support. Now, planning this again, this case, we utilized the denture as a surgical guide, the immediate denture as a surgical guide. You can see on the lower left slide, we removed the 2 anterior teeth and placed the implants immediately into the existing sockets. Very important to begin in this type of case in the anterior segment, because you'll get your parallelism through the extraction sockets. We place the parallel pins, and these are very, very important to utilize to keep your implants within 5 degrees. Looking at this right here, we are showing the retainers, the spacers in place for Ankylos implants. Again, we're placing implants posterior for posterior support. When we look at the reline, this is a better picture and indicator. We relieve the entire denture, try it in over the abutments to make sure we've maintained maximum intercuspal position. Regarding the last case, this is just showing the insertion, the immediate reline of the denture. Remember to remove any flash, and you can see the distribution of the implants provides us with better posterior support. This case was having an immediate upper provisional place. We went to a metal reinforcement. Now, if you choose not to use the immediate denture, you can make another denture for the patient with Vitalium reinforcement. There's a specific prosthetic technique that we utilize for that, and we can go through that at a later time. But this is showing the new final denture. More importantly, the precision nature of the retainers within the acrylic with some embedded Vitalium. So this is the final case, redeveloping form and function, utilizing syncone on the mandibular arch. Very, very effective, very simple, and cost effective. This is a secondary denture that was made subsequent with the maxillary case, but most certainly, if you feel comfortable with the immediate provisionalization that you provide, you can leave that as a permanent denture if you are happy with all the aesthetic, phonetic, and vertical components of the denture. Let's take a look at one more case type. This is just a panoramic picture showing us the long implants, 17 millimeter implants in the anterior zone and 9.5 millimeter implants in the posterior segments here. Taking a look at a case that was an advanced periodontal case on the maxilla, how do we manage and treat this? We're going to remove the teeth incisionless and place 4 implants and immediately load a denture into place so the patient has some capacity to function. Our goal here is to maintain as much of the architecture of the ridge as possible, and when we remove the teeth, we're placing implants, particularly in the 4, 13, 7, and 10 position. This was a non-grafted sinus case where the patient did not want to go through sinus grafting, so we placed the implants in the premolar and the lateral incisor region. So just an X-ray showing the post-op response of the bone on the Ankylos system. Day of surgery, we're showing the 4 syncone abutments, and they're 6 degree here, and we are using PRGF to graft and maintain the alveolar form and function. Very effective technique. And this is just showing the reline of the full denture. Now on the maxilla, because of the bone quality in this case, the immediate load nature of it, we chose to leave a full palatal coverage denture in as an immediate. 3 months later, as we move forward into the case, we are going to design a horseshoe Vitalium denture. Our goal here is to reduce the profile of the attachments. So this is a case, a good demonstration of where the syncone abutment is too long for the prosthetic interface. So in this case, we're showing here on this slide doing some laserplasty to develop ovate pontic form. And in particular, we have adequate buccal bone support for lip support as well. So our flange in the denture is not necessary. So one of the important components is to pre-diagnose the condition of the lip support. And many times you'll realize that you can develop a flangeless denture with ovate pontic design. So this slide is showing the healing after the plasty with the locator attachments, and this is showing the design of the Vitalium horseshoe denture on the maxilla. In particular, in these cases, we like to utilize an ovate pontic form with locators. Locators have a reveal of 3.1 millimeters, so they allow us to embed the attachments right into the identifying tooth positions without protruding through the facial profile. So in this case, as I said before, implant positioning is in the 4, 7, 10, and 13. If you can graft the sinus, it's a good idea to place implants either back in the tuberosity area, getting more posterior support if the bone is there, or ideally grafting the sinus to create better force dynamics and better distribution of the retentive capacity. But in these cases, you have more than enough retention with the distribution and the retention between the tissue support and the locator implant support. So this is the final case just showing what kind of aesthetics we can achieve with full denture prosthetics. So some of the important principles to review of the syncone overdenture system: insert the retainers with finger pressure, have the patient bite down normally during your reline. Keeping the denture in for 2 weeks is critical to act as a splint, reducing any micro-movement at the bone-to-implant interface. Using 6 degree on the posterior and 2 4s on the anterior is a good idea. I would not use all 4 degrees. And remember, your prosthesis is both tissue and implant supported. So you want to have good tissue support because this is not a fully implant supported type of prosthesis. Remember, planning is the critical component, diagnosing, moving forward in that dimension, and you'll have total success in your case selection, treatment, and outcomes utilizing the syncone system. Thank you very much for listening, and I hope you enjoyed the lecture.